Today's quiz is on calcium channel blockers, a key drug class used in managing hypertension, angina, and arrhythmias. This quiz features 10 multiple-choice, scenario-based questions designed to test and strengthen your understanding. Each question comes with 5 options, followed by the correct answer and a clear explanation. For a comprehensive review of calcium channel blockers and their mechanisms, check out the companion video linked in the description. So, let's begin. Question 1. Mr. Anderson, a 64-year-old man with a history of hypertension and stable angina, is currently prescribed amlodipine 10 mg once daily. He reports gradual swelling in his ankles that worsens throughout the day, without shortness of breath or orthopnea. His echocardiogram is normal, and renal and liver function tests are within normal ranges. Which of the following is the most important explanation for his symptom? Option A, increased venous pressure due to sodium and water retention. Option B, precapillary arteriolar dilation leading to increased hydrostatic pressure. Option C, direct nephrotoxicity of amlodipine causing renal sodium retention. Option D, impaired lymphatic drainage due to smooth muscle relaxation. Option E, increased right-sided heart filling pressures caused by reduced cardiac contractility. The correct answer is option B, precapillary arteriolar dilation leading to increased hydrostatic pressure. The explanation is that ankle edema from amlodipine is not due to fluid overload but rather precapillary arteriolar dilation. This dilation increases hydrostatic pressure in capillaries, pushing fluid into the interstitial space. Because venous tone remains unchanged, the imbalance favors fluid leakage into tissues. This explains why amlodipine-related edema is dose-dependent and not typically associated with heart failure. Question 2. Mrs. Johnson, a 72-year-old woman with long-standing atrial fibrillation, is taking verapamil for rate control. She presents with dizziness and fainting episodes. On examination, her pulse is 40 beats per minute and blood pressure is 90/60 mm of mercury. ECG confirms bradycardia with first-degree AV block. Which of the following is the most appropriate immediate management for this adverse drug reaction? Option A, administer intravenous calcium gluconate. Option B, switch verapamil to amlodipine. Option C, administer intravenous magnesium sulfate. Option D, give oral digoxin loading dose. Option E, stop verapamil and start high-dose beta blocker. The correct answer is option A, administer intravenous calcium gluconate. The explanation is that severe bradycardia from verapamil toxicity requires immediate reversal of calcium channel blockade. Intravenous calcium gluconate counteracts the negative inotropic and chronotropic effects by providing extra calcium for cardiac cells. This stabilizes heart rate and blood pressure while more definitive measures are prepared. Other options like switching drugs or adding digoxin are inappropriate in acute management. Question 3. Mr. Williams, a 55-year-old man, is prescribed nifedipine for severe hypertension. He asks about the differences between calcium channel blocker subclasses. All of the following statements about CCB subclasses are correct except Option A, dihydropyridines such as nifedipine primarily act on vascular smooth muscle. Option B, verapamil has the strongest negative inotropic and chronotropic effects. Option C, diltiazem has both cardiac depressant and vasodilatory actions. Option D, amlodipine is short-acting and often used to terminate hypertensive emergencies. Option E, non-dihydropyridines are effective for supraventricular tachyarrhythmias. The correct answer is option D, amlodipine is short-acting and often used to terminate hypertensive emergencies. The explanation is that amlodipine is actually a long-acting dihydropyrin with a gradual onset of action. Short-acting nifedipine, not amlodipine, was once used for hypertensive emergencies but is no longer recommended due to risks. Amlodipine's extended effect makes it useful for chronic hypertension and angina. All the other statements correctly describe calcium channel blocker subclass properties. Question 4. Ms. Harrison, a 30-year-old pregnant woman at 26 weeks gestation, presents with newly diagnosed chronic hypertension. Her doctor considers starting nifedipine. Regarding calcium channel blockers in pregnancy, which statement is not correct? Option A. Nifedipine is considered relatively safe in pregnancy. Option B. Verapamil can be used if arrhythmia control is required. Option C. Amlodipine has less safety data compared with nifedipine. Option D. All calcium channel blockers are contraindicated in pregnancy. Option E. Nifedipine can be used for acute severe hypertension in pregnancy. The correct answer is option D. All calcium channel blockers are contraindicated in pregnancy. The explanation is that calcium channel blockers, especially nifedipine, are widely used for hypertension in pregnancy. They are considered safe, with nifedipine often preferred for both chronic and acute cases. Verapamil can be used in arrhythmia control, and amlodipine has less established safety but is not absolutely contraindicated. Therefore, saying all CCBs are contraindicated is inaccurate. Question 5. Mr. Clark, a 47-year-old man with a history of heart failure with reduced ejection fraction, presents with poorly controlled hypertension. His physician considers adding a calcium channel blocker. Which of the following calcium channel blockers is the most appropriate choice in this patient? Option A. Verapamil. Option B. Diltiazem. Option C. Amlodipine. Option D. Nifedipine immediate release. Option E. None of the calcium channel blockers are safe in HFrEF. The correct answer is option C. Amlodipine. The explanation is that amlodipine is one of the few calcium channel blockers shown to be safe in HFrEF. Non-dihydropyridines such as verapamil and diltiazem worsen cardiac contractility and are avoided. Immediate-release nifedipine increases risk of reflex tachycardia and adverse outcomes. Amlodipine provides effective blood pressure reduction without worsening heart failure prognosis. Question 6. Mrs. Robinson, a 69-year-old woman, is being treated with diltiazem for angina and also takes simvastatin 40 mg at night. Her liver enzymes are found to be elevated. Which of the following is the most important explanation for this interaction? Option A. Competition for renal tubular secretion leading to reduced clearance. Option B. Induction of CYP3A4 leading to toxic metabolites. Option C. Inhibition of CYP3A4 metabolism of simvastatin causing increased plasma levels. Option D. Chelation of simvastatin in the gastrointestinal tract reducing absorption. Option E. Displacement of simvastatin from plasma proteins causing toxicity. The correct answer is option C. Inhibition of CYP3A4 metabolism of simvastatin causing increased plasma levels. The explanation is that diltiazem inhibits the cytochrome P453A4 enzyme, which is responsible for metabolizing simvastatin. This interaction increases plasma concentrations of simvastatin, raising the risk of hepatotoxicity and myopathy. Elevated liver enzymes in this patient are explained by excessive simvastatin exposure. This is why simvastatin doses are restricted when combined with diltiazem or verapamil. Question 7. Mr. Mitchell, a 58-year-old man with hypertension and type 2 diabetes, was recently started on felodipine. After 2 weeks, he reports headaches, flushing, and palpitations. These symptoms are likely due to reflex sympathetic activation. All of the following strategies can reduce these effects except: Option A. Use of a longer-acting dihydropyrin formulation. Option B. Concomitant use of a beta blocker. Option C. Gradual dose titration of the calcium channel blocker. Option D. Switching to a non-dihydropyrin calcium channel blocker. Option E. Increasing felodipine dose rapidly to achieve therapeutic levels. The correct answer is option E. Increasing felodipine dose rapidly to achieve therapeutic levels. The explanation is that rapid dose escalation worsens reflex sympathetic activation rather than reducing it. Long-acting preparations and careful titration reduce fluctuations in blood pressure, thereby minimizing reflex tachycardia. Combining therapy with a beta blocker also blunts sympathetic overactivity. Switching to a non-dihydropyrin is another reasonable option if symptoms persist. Question 8. Baby Thompson, a 4-month-old infant with congenital long QT syndrome, presents with recurrent supraventricular tachycardia. The cardiology team considers using a calcium channel blocker. Which of the following statements regarding use of calcium channel blockers in infants is correct? Option A, verapamil is safe and first line in infants under 1 year of age. Option B, diltiazem is absolutely contraindicated in all age groups. Option C, verapamil can cause severe cardiovascular collapse in infants. Option D, amlodipine is recommended for acute arrhythmia management in infants. Option E, nifedipine is the drug of choice for arrhythmia in infants. The correct answer is option C, verapamil can cause severe cardiovascular collapse in infants. The explanation is that verapamil is contraindicated in infants under 1 year due to risk of profound hypertension and cardiovascular collapse. Their immature myocardium is highly sensitive to negative inotropic and chronotropic effects. Alternative agents such as beta blockers are preferred for arrhythmia management in this age group. This safety concern is specific to very young children, making verapamil unsuitable. Question 9. Mrs. Miller, a 63-year-old woman, is being treated for Raynaud's phenomenon with nifedipine. She asks about possible side effects. All of the following adverse effects are well documented for dihydropyrin calcium channel blockers except Option A, flushing. Option B, gingival hyperplasia. Option C, peripheral edema. Option D, constipation. Option E, palpitations. The correct answer is option D, constipation. The explanation is that constipation is a well-known adverse effect of verapamil, not dihydropyridines like nifedipine. Dihydropyridines more commonly cause vasodilatory side effects such as flushing, headache, palpitations, and edema. Gingival hyperplasia is also recognized with long-term use. Therefore, constipation is not a typical adverse effect of this subclass. Question 10. Mr. Evans, a 59-year-old man with poorly controlled hypertension, has been prescribed verapamil. During a routine review, he complains of constipation and fatigue. On examination, his heart rate is 48 beats per minute. Which of the following not suitable monitoring parameters would help detect verapamil toxicity? Option A, blood pressure monitoring. Option B, heart rate monitoring. Option C, electrocardiogram for PR interval prolongation. Option D, serum creatinine monitoring for renal impairment. Option E, liver function tests for hepatotoxicity. The correct answer is option D, serum creatinine monitoring for renal impairment. The explanation is that verapamil toxicity is best assessed through cardiovascular and hepatic monitoring. Blood pressure, heart rate, and ECG changes such as PR interval prolongation reflect its cardiac depressant effects. Liver function tests may detect hepatotoxicity related to metabolism. Serum creatinine, however, is not directly relevant to detecting verapamil toxicity, as it is not primarily renally cleared. Conclusion. That wraps up our revision on calcium channel blockers. I hope you found this quiz session engaging and informative. To deepen your knowledge further, consider reading resources like Katzung and Trevor's Clinical Pharmacology, Rang and Dale's Pharmacology, and the British National Formulary, BNF. These references will solidify your understanding and enhance your preparation. Also take note that in this video, any mention of guidelines will specifically refer to those outlined in the BNF.